joining us today. This is our second in the series of our, it's a Cancer Survivorship ECHO, but we've converted for April into a COVID-19 and cancer mini-series so that we can better meet the needs of all of our catchment area across the state and across the region, and our partners who we work with to help care for cancer patients, and all the healthcare professionals that we support and work with as well. So thank you all for joining us, and I'll go ahead and kind of get started by just quickly reviewing, because I know some of you probably, again, are sort of new to ECHO. So we'll talk a little bit about, just real quick, like our housekeeping, so that you are familiar with what we are doing on a Project ECHO. And can everyone see my screen okay? With the slides? Great. All right, so we'll just kind of cruise through. Tonight we do have, once again, some of our content matter experts. Dr. Sinclair, Jennifer Klepp. It sounds like some little person is on there as well. We have lots of coworkers and family and animal partners that tend to join in, and that's okay. But tonight we have Dr. Christian Sinclair, who's joining me as our course director for the mini-series. And then we also have Dr. Lauren Nye, who's a breast medical oncologist, and Shauna Wright, who's our associate director for KU's Center for Telemedicine. So we're excited to have them join in along with all of you. Here's our quick review of what we will be talking about. And let me see how we can get that line off of there. Tracy, do we know how to get that line off of that?
If you can make me a co-host, I can get rid of it.
That would be perfect. Tracy will make Dr. Wright a co-host, and that is why we have a team that works well together. Great. So here's our agenda. Quickly, we'll go through housekeeping, and then we have a great discussion tonight, starting with the infodemic of COVID-19. And that's where we really want to go through the importance of accurate information, fact and fiction, and how do we put that into perspective, both for our knowledge as well as how we translate that and communicate that to our patients. And then in kind of light of how we discuss cases, usually as part of an ECHO, we're going to sort of talk about case conceptualization using a 4x4 model, and Dr. Sinclair will lead us in that discussion. We'll highlight some updates, again, with telehealth, and we'll end the session with a little bit of self-care for our healthcare professionals. You are part of this conversation, so once again, we want you to be part of this community of practice. So we'll encourage you to use the chat feature, as well as we have multiple polls built in for tonight so that we can get you engaged in the conversation. Quick review of our continuing education credits. We have physicians, nursing, social work, as well as certificates of attendance. So anyone who needs that, please make sure that you follow up here in 1 second, or we'll give you the information on how to get your credits. Conflict of interest disclosure, no one has any disclosures except myself, as you can see down here at the bottom. And if you will have access to these slides on the website at the Masonic Cancer Alliance website. On our homepage, we have a little link, and you can click to all of our resources, including the slides and the information in the toolkits. Here is your continuing education credit information for tonight. The identification code is 71 YALD, so sort of Southern with a D on the end. Deadline is next week. You can do this by phone, on the website, or on the app. We will again show this at the end. So 71 WALD will help you get your credits for tonight. Our funding source we always want to acknowledge and thank is a cooperative agreement by the Centers for Disease Control and Prevention through the Kansas Department of Health and Environment, along with support from the KU Cancer Center and the Masonic Cancer Alliance. So thanks to all of those who support us building this community of practice. And so we are going to do a little bit of check-in tonight, because last week we didn't, and even though we are living in the world of COVID, and the ECHO Institute has given us a little flexibility with how we do check-in, I think we should kind of pause here, see who's on, and especially some of the newer people who are joining us. We do want to encourage the meet and greet through our community of practice. So you saw a lot of the organizations that are participating. So if anyone would like to say hi, would like to, especially if you're new to the community, please feel free, or anyone who's not new, and either put your name in the chat box, which we want everyone to do, so we can make sure that we count you as attending. Please go ahead and do that, as well as unmute yourself, and we will say hi and welcome you to the community tonight. And don't be shy.
Hello, this is Vicki Portwood.
Hi, Vicki. Good to see you.
Good to see you. I got done with clinic early, so I'm excited.
Great. We are so happy to have you. And Vicki, tell us where you're from.
Coffeyville Regional Medical Center, which is on the Kansas-Oklahoma border.
Great. Thanks for joining. All right.
Hey all, this is Luca Sarolia calling in from the ECHO Institute, and just a huge thank you to this group. These are kind of the group that's setting the gold standard for COVID-19 response in cancer, and we're honored to participate and just to be witness, so thanks for having us.
Oh, thanks, Luca. We are very appreciative of all that the Institute does, so thank you for joining and for your support.
Hi everyone, Matt Bouchonville here. I work with Luca. So nice to see you. I also work at ECHO Institute.
Great.
One of the associate directors. Thanks for having us.
Thanks, Matt.
Hi, this is Hope Crable, and I'm with the Masonic Cancer Alliance. So thanks everyone for joining us tonight.
And thank you, Hope, for your continued support of our Project ECHO. All right. There's some folks from Salina. I see Stephanie's on. From Tammy Walker, we have Carla from Olathe. If you guys want to say hi, good to see you guys. And Karen, do you want to introduce yourself? You're new to the group.
Hi there, it's Karen Dennis Collar. I'll be joining the MCA officially on Friday. So I know I've emailed with some of you in the last few weeks, and it's been a long time coming. I think it's been almost 60 days since I accepted the position and had to give notice to my old job. So I'm really excited to be joining the team, and Hope and I were emailing yesterday, and she said, well, there's a Project ECHO tomorrow. So I said, great, I'm happy to join. So it's nice to meet everybody, and I'm really excited to be able to be a part of this team.
Great. And you'll get to know a lot of people in the community. So we're glad you joined us tonight. Thank you.
Thank you.
Yes, you bet. All right. Who else would like to say it? Anyone else want to join in and say hi tonight? You guys are doing well in the chat box, which we always appreciate. And Dr. Barr is on from Lawrence. So anyone else who feels like you want to chime in, do so, or we will continue on. But normally we do like to do the check-in. This is a good way for us to, once again, continue building our community. And we know a lot of you, but when there's new people, we want to meet and greet and continue building that relationship. So thank you again for saying hi. And again, these are the organizations signed up for today. And so people will kind of come and go, and we just want to acknowledge all the participants who are registered. So thank you, and thank you for your continued participation. All right. So we will be recording. So just know that that's part of sort of the process that we do, so that not only we can post our echoes on the Masonic Cancer Alliance website, but it gives us a way to have that enduring material. So please feel free to reflect back or to share that with your colleagues, because I think you're really going to like some of the dialogue that we discussed tonight. Also, some helpful hints. Many of you are getting so good at using your cameras now. Some of you have noted that you don't have a camera, and that's okay. We get that, or maybe you're driving, or maybe you're cooking dinner, and all those things are fine. But we do want to see you, and that helps us engage with you. We will keep you on mute if you're not speaking, which would be great. And we want you to speak clearly and concisely, but we would love to see you and try to show your face if possible, because we do want to get to know you. We do use internal polling, and next week we may try an external poll. So we're going to try to get creative, but tonight we will do internal polling through Zoom, and it's very easy. So basically a question is going to pop up. You're going to go ahead and answer that on the screen, and then we'll show those anonymous responses so that you can kind of see what your peers on the call are thinking, or how they're incorporating different aspects of care into their practice. So I think this is a really good way for us to share and also encourage communication. So here's our first poll that we're going to try out. Does your organization currently manage any patients with cancer who've also tested positive to COVID-19? So go ahead, and Tracy will put the poll up. As you can see, you're just going to answer yes, no, or maybe you're not sure. And then we will stop the poll here at about 10 seconds, and we'll see the final answer. All right, Tracy, you can stop the poll. There we go. So about 30-30-30, we're split between all possible answers. So I think the important part of this is that even if you aren't, because we know that obviously things are kind of starting at the coast and working their way in, this is a great opportunity for those of you across the catchment area where this is just getting ready to hit your location, to have some of the tools and experience that we've been experiencing in Kansas City and across obviously the area. So we're going to start out by talking a little bit about this infodemic. And this is a new term, right? So we have all these new terms. Social media sort of help propagate this, but infodemic relates to fact or fiction really responding to the pandemic. And there's a lot of information, obviously, that's out there, and a lot of information that our practices need to flex or respond to. And as we talked last week, there's a lot of response that needs to happen, even in a fluid way within a given day. So that flexibility is important, and we do need to learn from our peers. It's interesting, some of us have participated in a happy hour with breast oncologists from across the country, and it's really fascinating to hear the experience in New York and New Jersey compared to Florida, compared to Texas, compared to San Francisco, and compared to what we're experiencing in Kansas and across the catchment area. So really hearing these differences puts into perspective that yes, there's some common elements that we all obviously need to be aware of and need to be educated on, but we also have different experiences based on our volume, our needs, and the accessibility that we have. So I think that that's been a really interesting discussion because it's not one size fits all. But the first thing that I think is most important is really understanding the accuracy of the information that you're exposed to. And recently, and this was literally like 2 days ago, all this is sort of hot off the press, is that Facebook started removing posts that discourage or have negative connotations regarding social distancing. So in particular, we know that social distancing works. It's not just from this pandemic that we've seen the results of that. This has been established even, early pandemics that occurred. People that utilize social distancing had improved outcomes. So not only are organizations and platforms like Facebook removing inaccurate posts, but Google has actually banned different apps and different info sources from their where you can go and download different apps on like an Android platform and what have you. And so I think that this is a real good way of social monitoring to make sure that the information that we have access to is accurate, it's available, and it's really serving the right purpose, because misinformation can obviously lead to a lot of undue stress and anxiety, but also that misinformation you've heard in the news led to healthcare professionals, in particular in other countries, who were wearing scrubs or who were identified as healthcare professionals, really being victimized by people that found that they were carrying maybe the virus, and this was obviously something that the population was very scared of. So I think the important part about this information gathering is essential in our current environment. And I would like to kind of pause here and ask the group, do you feel that there are questions that you have, or are there certain outlets that we are definitely utilizing that are safe and reliable. We talked a lot about the Kansas Department of Health and Environment. We talked that KU obviously is part of that focus as well. So anyone want to chime in?
So Jen, I'll chime in. And I'm Lauren Nye. I'm a breast oncologist at KU. And I think one of the things that we've also seen is, sorry, that's a timer going off, working from home. One of the things we've also seen is a lot of publications going into press very quickly and talking about new drugs that we should be using, how we should be treating patients, should we be doing antibody testing, and we need to be careful as to trying to implement those things into clinical practice right away without good randomized controlled data or validated studies. Because I'm even finding, in our well-known journals that we are seeing things go to the press very quickly, and we have to remember that there's still research and use caution in putting those things into practice right away.
It's a great point. And anyone else having those types of experiences or questions or comments from your patients or colleagues? You guys are very quiet out there today. And is anyone writing in the chat box something? Some Dr. Sinclair is saying even within our own organizations and professional societies, there's this tidal wave of information. Absolutely. And I think what Dr. Nye also referenced is this is a nice example. This just came out yesterday in Oxford Press. And I don't know if you guys have seen this, but this is the article, and we'll go ahead and put that in the toolkit. This was an article highlighting, oops, sorry about that, the need for fact checking and then how much information is actually being reconstituted and misinformation. So fact checking is up over 900% since January. So that's an enormous responsibility. So there's lots of sort of watchdogs, which we know there's pros and cons to that. But the reality is to be up 900% is huge because there is a lot of misinformation. Or as you can see by the second figure, it's what they're calling reconfigured. So a prime example is that maybe someone sees a tweet or sees a Facebook post and they re-message that, right, to their friends. And people don't always do fact checking on information, especially like Dr. Nye said, maybe it's a reliable source, so they're just going to go ahead and repost that or share that with their network. And I think the important part of this is that 60% of what this Oxford Press article highlighted is that it's reconfigured. So maybe somebody pulled out a nugget or just reposted. But almost 40% is flat out what they called fabricated, which is literally where it was sort of, here was a concept and it was interpreted or relayed in a way that was inaccurate. So I think that this figure in particular is very concerning because of that misinformation. And does anyone have a reaction to that? Does anyone find that a little concerning, or is this to be expected in the current, I mean, is this some, kind of our new normal where we have to do our due diligence and fact checking because, even some of our reliable sources aren't as reliable as they used to be?
I think one of the examples is a lot of people have seen the very cool and well done image of the person running, showing the spewing of their germs all over, and why some places are saying you shouldn't be out running or walking because you're going to spread coronavirus. And if you actually go and understand how that was done, there's been some human scientists who have broke that down and said, well, you're not standing there with a spray bottle spewing your germs at people in a wind tunnel as you're running past them. That would be kind of the perfect storm that would recreate that situation that the image is showing, that we're just spreading our germs all over, walking past someone or running on a trail, and we should all stay inside. And that really probably isn't the reality of the situation, but even all of my family members have spread that throughout Facebook, and, you shouldn't do this or you shouldn't do that, or people who go outside are getting called out by other neighbors that, they're not staying home as they should be. And so I think that's one of the examples. And there's many other, like the malaria drug and the hydroxychloroquine and everything, that we just have to be careful how we repurpose information.
Absolutely. And I know some of us, especially if you're healthcare professionals, you've got a invitation to be part of the HERO study, which is looking at the malaria drug. It's a registry plus a randomized trial. Those are ways where we are participating, and I think we can be very active participants. But a lot of the information sharing can, especially by family members or those who are not in the healthcare profession, can be a little bit fact or fiction. Anyone else have any examples or any insight you'd like to share? Or has anyone seen anything that you found just utterly fascinating that you think we all should know about?
Yeah, so this is Christian Sinclair for the University of Kansas. I would really love to hear from some of the people who are on cancer care teams across the state and across the country on this call, because I've been surprised as a palliative care physician working in a cancer center. I'm having patients come to me with lots of questions about, do I know about this? Do I know about that? Why don't I know about this other thing? So I'm curious how some of you have handled those questions, or I guess it would be good to hear, are you guys not getting any of those questions at all? Because this feels like a real big information responsibility of clinicians for something we're still learning about. So I guess I will challenge our attendees. If you're not hearing it, I'd also like to hear, hey, if we're not hearing it, this isn't a problem, this isn't an issue.
Great. And Vicki down in Coffeyville, have you guys had any, what are the types of questions you guys are getting?
I think that they don't really think it's real, that it's a big deal, that it's really as bad as what everybody says it is. And maybe that's because we don't have a large load of cases. But I think as more publicity has been out, people are taking it more seriously. You know, it's probably affecting someone they know now because there's so much of it. But in the beginning, people didn't really believe it was a big deal.
Kind of slow to react. Yeah. And I know that Hope and I were sharing an article the other day from one of the newspapers in Topeka, you know, that one of the hospitals in Topeka has now a cluster of nurses that are COVID positive. So these do happen. And yes, it tends to be a lot of senior facilities or rehab facilities. We've had several church outbreaks that we heard from Dr. Greiner last week. So, you know, there are these sort of clusters that are happening, but then now there's a lot that aren't part of those clusters. And I do think that the disbelief is not uncommon. And we talked earlier, there's a lot of, some entities report a lot and some don't report any. So I think that patients aren't really sure, you know, what is real, because not everybody's reporting the same way. And I think that's been sort of an interesting lesson learned, is that we don't have a standard sort of way that we have to report, whether we're a healthcare facility, whether we are a, maybe it's a rehab facility or something else. So I think that's unfortunate, because then there's a lot of unknowns. And so maybe you're just going to assume that hospital X has no cases because they're not reporting anything, but that's not actually true. They just don't have to, or don't have the same social responsibility to report. So I think that's a interesting question that will probably be well dissected post-COVID to try to standardize that a little more.
We also hear a lot of, well, lots of people die from the flu every year, probably more than have died from COVID. So why is this such a big deal?
Mm-hmm.
And what do you say?
Yes.
I tell them that a higher percentage of the people that get COVID don't respond. So that's why it's a bigger deal.
Great. So you kind of right-size that information, which is awesome. So good. Well, thank you guys for joining that discussion, because I think that those are really, you know, this fact or fiction is there. And I think this is just a good lesson learned of how we need to control a lot of that messaging and help our patients get access to accurate information, as well as, like Vicki just highlighted, having responses that we can give to patients that are accurate and will help them reduce their anxiety.
Hey, Jennifer, one other thing that I want to highlight on this information issue is for all of us who've been working with patients and families who have cancer, one of the things we've seen is that in cancer care, people will do their research. They want to look up stuff, and they come to their doctors and their cancer care teams and say, have you heard of this? And this is just about cancer treatment care. And we know that looking for alternative treatments is a very common thing in our patient population. And so I think we're seeing versions of that also with coronavirus, to say they're already used to looking things up and trying to be really empowered patients, and their cancer care teams try to take some of that information, validate the stuff that has good information behind it, make sure we're helping keep them safe and avoiding things that might be more dangerous and don't have a lot of evidence behind them. So I think using some of the same principles we do when people are looking up alternative cancer treatments, we can apply some of those same principles to coronavirus. Because I've had 2 patients who have basically tried to get me to promise in advance to prescribe them hydroxychloroquine and azithromycin. And they said, if you won't do it, I'll go ask the oncologist. So which one of you is going to do that for me? And I was surprised. It was 2 different patients kind of asking the same train of thought, trying to make sure I was going to do that ahead of time. And so what I tried to say was, if you do get sick, we would consider that if that's what our infectious disease docs were recommending, it'd really be a shared decision. And they basically both took the concern that I was pre-rationing care for them and trying to keep them away from it. And there was both of these patients were, as a palliative care physician, I was seeing for pain and anxiety and other reasons. But that was the thing that was weighing most heavy on their mind, and trying to help give them the confidence in the healthcare system to treat them equally, while also trying to share what is our best information that we have. I found that really challenging, even as someone who focuses a lot on good communication with patients. It was some of my most challenging conversations.
That's a great point. And I think the hard part is, patients are very savvy consumers. And we in oncology often joke that patients are coming in, with these lit reviews, either they do or their kids or relatives or someone at their club does. And they are very savvy at having a network to help them gather this information. So this is one more extension of the behavior that we already see very commonly in cancer patients. And I think, Dr. Nye, didn't you have a patient who came in the other day who basically had brought like a table, like an entire spreadsheet of all the different anti-hormones and the side effects, and she was like so well informed. And that is not that uncommon for a lot of our patients to really do that level of due diligence.
Yes, definitely. And a lot of our patients are being proactive and calling us with their questions about COVID and, should they really be getting that treatment? Should they be really coming in? And so they are kind of paving the way and asking the questions before we even get the opportunity to contact them. So I think they're very worried about weighing the risks and benefits, and they're looking for our insight, but they're also very afraid, I think, of the virus or the virus stopping them from getting their treatment.
So we're going to come back to that risk cost benefit as our next point of discussion. But building on what you just said, patients are calling in, but I feel like there's also been a lot of patients not calling in. Like you usually have a steady stream either through a patient portal or through a phone call. So do you feel that some of the normal questions that patients were calling have kind of tapered off? Like, are you seeing any difference in how patients are communicating?
I asked my nurses that the other day, and they did feel like the number of COVID-related calls had gone up. Should they be working? They have a cough or things like that. But the number of calls about my joint ache from my aromatase inhibitor and things like that have gone down. I have mouth sores. Those types of calls seem to be a little bit less. And I don't know if that's just our interpretation. We don't have a way to pull those numbers from our phone calls notes that are documented, but I think it would be interesting to look at, are patients self-managing, or are they just afraid to call with
Right.
a symptom?
And it probably is a mixed bag. Anyone else have any comments on that from anywhere across our community here? Are you seeing more or less patients calling in, communicating with you? Okay. All right. So I think we're going to feed into that comment that you brought up about risk stratification. And I think this is a really interesting topic. And Dr. Sinclair, I'm going to let you kind of guide this discussion. And you also are a host, so you can kind of click through to your slides, and we have a couple poll questions built in to help guide us into your 4x4.
Excellent. Well, thank you very much. So I know we've asked you guys a few times to give us your input, and this next couple slides, I'm really going to need some input, because we need to build a idea of our typical patient population and what we need to think about their different risk levels when it comes to their risk from cancer, cancer progression and complications from cancer, and their risk from coronavirus. So you can use the chat box, or you can turn off or unmute your mic and just feel free to speak up and share what you think. So when you think of the different types of patients, the archetypes of patients that are coming through a cancer center, we want to better understand what their risk is. And to do this, all our different organizations are trying to come up with different policies. And while we're not going to be able to come up with a policy that fits everybody, we think if we can help cancer care teams start to risk stratify a little bit, then it's going to be easier for you to identify, this is a patient who absolutely needs to come in and be seen. This is a patient who we can hold off. Maybe we can do a telephone visit or a video visit and keep them safe. So let's go ahead and go to the next slide. I'm trying to advance it.
There you go.
There you go. Okay. So thinking of this 4-box model, on the vertical axis, we have risk of harm from cancer being low or high risk. And then at the top, we have risk of harm from COVID-19 being low or high. And I want you to think of the different patient interactions that might be in one of those boxes. So I'm going to start you off with like an easy one, kind of think of like a survivorship checkup, someone who is 5 years out. If you can go back real quick, Jen. Survivorship checkup, that might be low risk from harm of cancer. We've been surveilling them. They're multiple years out from their cancer. They're not immunosuppressed anymore, so they should be able to be considered more part of the general population. And while they have risks, having them come in this month or this week isn't as important. So they might be someone, you say a survivorship checkup, a patient in that category is probably low risk from harm of cancer and low risk of harm for COVID-19 in the immediate future. So let's hold off on either making that appointment or just have a quick phone check-in and schedule any scans or surveillance testing for later on. So that's kind of what we're looking for here. So let's go to the next slide, John. So in the chat box, I want you to ask or type in what other patient populations or classic patient archetypes would you think would fall in this box, and where would you put them? Low risk of cancer, high risk of cancer, low harm from COVID, or high harm from COVID.
And Tracy, you can put up the poll too, so they can answer that. Here we go.
All right, so the population, which population falls into the low risk box? Someone who's newly diagnosed, a cancer survivor, patient who's on their last cycle of adjuvant therapy.
I think these guys are really smart, or they were listening to you, Dr. Sinclair.
I forgot that the first question was that one.
See, you led them in. You guys are awesome.
All right, but we got 14 votes, so good. So that cancer survivor, they're really far out from their diagnosis or on endocrine therapy, so great. Let's see, what population falls into the high risk box? So high risk of COVID, high risk of cancer complications.
And the next poll will go up momentarily. Here we go.
So this high risk box, patients who are actively undergoing cytotoxic chemo, those who have undergone a transplant, all the above. Okay. It's like all the above. Got one out on that one. So if we, and I want you all to feel free to also type into the chat box what's a different patient population that maybe we didn't ask about that you think may fall in one of those, or open up your mic and say, hey, this is a patient population that I see, and I'm not actually sure where they'd fall in, and let's have a discussion about it.
Dr. Sinclair, I guess I would start by defining how I think of high risk. Sorry, I think my video popped up. High risk for COVID. So I'm thinking in an oncology population of the study that showed that our cancer survivors within that first year of cytotoxic treatment, so while on cytotoxic treatment and kind of within that first year out, are probably those at high risk, where those cancer survivors are still at an increased risk compared to the general population who has not had a cancer history, but not as high risk.
Excellent. So here in this slide, we put up a couple of different situations that we think, this is where the general population with this issue might fall in. So someone who's getting routine labs and scans, maybe they're on immunosuppressive therapy, whether it's steroids, whether it's immunotherapy, maybe they're in between, or you're holding off on treatments, or they just came out of the hospital with a surgery. You feel relatively confident that what's going on with their cancer is at least well controlled for right now, but clearly their body has gone through a lot and is much more susceptible to an infection at that point. So their risk from coronavirus is much higher. So that might be someone who you'd say low risk of cancer, but high risk of COVID-19, at least in the immediate future. Whereas someone who has a new early cancer diagnosis or a progressive advanced cancer, it's not necessarily the higher risk from COVID, but actually what's going on with their cancer. If we don't do something about this now, the complications of their cancer progressing may be much more dangerous to them than any risk of coronavirus. And so trying to figure out how do you plan around surgeries, how do you plan around new starts of treatment, what is your organization going to do about testing people before they undergo new treatment regimens, or even the same treatment regimen that they're on? Are you checking fevers? All these sorts of things go into policies and procedures, and hopefully your organizations have started to talk about this, even if you haven't had a lot of cases in your area, because your patients and their families and your colleagues are all going to wonder what's the right thing to do in this situation. And the more you as a team, as an organization, can get on the same page, I think that's probably going to be better for your organization and your patient population. Dr. Nye?
Well, Vicki brought up in the chat box that, you also have to take into account kind of their comorbid conditions, their age, and all of that. And so it does become kind of that complex thought process and then shared decision-making to determine on a personalized basis, where a patient falls into this 4x4 table.
And definitely this table is it's more of a thought exercise. We can definitely think of exceptions to all of those, but it might give you and your team a way to say, all right, at least our first plan of action for someone who falls into this category is to delay things or to rapidly get them into their next stage of treatment, because we've considered these things at a broad level, but still definitely taking an individual approach to our patients.
Yes, at KU, we were asked to actually write out our charts, our 3 tiers of kind of risk from cancer and how we would manage those in all of our breast cancer subdisciplines. And it was a really difficult exercise for me. I mean, we have national guidelines out there that have come together in terms of breast cancer management from the surgical standpoint and the medical oncology and radiation oncology standpoint. and built those guidelines, but still trying to interpret them and reframe them in your patients at your institution is difficult, because you think about, well, what if, what if, and you're trying to weigh really theoretical risks and benefits, but the harms are really there.
And Dr. Nye, any comments on your teammates, your colleagues all being on the same page? Like what would happen if, well, I have a different standard than you, Dr. Nye, about when I go to surgery. How could that be?
That is when I wrote in as determined by provider.
Yeah.
Because like was pointed out earlier, it depends on the individual's comorbidities and other risks as well. So I don't think there is a one size fits all, and you do have to know the patient. But yes, there was variability, and I think that's within our own group in terms of how we would want to interpret those, but also you see a lot of pessimism nationally on how one place is doing something versus another. And it's really because we're in a different environment. We're not in the New York situation right now. And even within our own city, we have different levels of PPE, different levels of ventilators, different levels of capacity at different institutions. So we're absolutely going to be managing our patients differently based on that capacity. And it's not right or wrong, it's doing what's best for the patient. So it's not really something you can compare to others.
I think that's important, that individualization. We often, our gaze is at individualizing the care for the patient, but I think looking at what our own institution resources are and priorities and availability of expertise and tools to actually care for the patient, it needs to be under consideration just as importantly. So Vicki, I think, was the one who highlighted this, that she was noting that some patients don't see this as a risk. So let's look at another 4-box exercise, kind of using the same idea, but this is not about the patient interactions with the system, but the patient perception. So you have a patient who comes in and they think they're at a high risk of their cancer causing a complication or progression in the next several weeks. And they also think they're at high risk of COVID-19. And that's their perception, but your perception as a clinician may be different, that you may think, no, that I'm not as worried about your cancer, but I'm much more worried about the coronavirus, or I'm much more worried about your cancer and less worried about the coronavirus for you right now. So trying to think of different ways in which our patients may come to us, and how do we adjust or support them to make sure that we have a shared understanding of where we think their risk is. So thinking of different ways to say, if your risk from coronavirus is high and your risk from cancer is high, do we need to think about taking a short-term break from treatment that might shift you a little bit, where your risk from cancer is high, but your risk from coronavirus is low. And you have to weigh, that patient has to weigh with their provider what's most important to them. And I think in some patients, we see a lot more fear from coronavirus. In other patients, we see a lot more fear from cancer. And they look to their providers to help give them the sense of, is my risk really placed in the right box? And they want to talk it through with their providers. So I think this is something that some of you may have already seen, and if you haven't, we're likely to see that some more. If you go to the next slide, this is kind of the situation that was shared earlier. Maybe someone thinks, hey, it's low risk from coronavirus, I'm not really worried about it. And part of our job is to say, oh no, actually you're someone who I'm really concerned about with your immunosuppression from your different therapies. And so you're actually at high risk from coronavirus, and your cancer treatment or your cancer progression is not something that I'm really worried about right now. So let's really talk about best practices of social distancing and hand washing and that sort of thing. So just some different ideas of how patient perception may shift in our role as clinicians.
Do you mind going back a slide?
Yeah.
So I just really loved these tables to provide to our teams to help talk to a patient. I think it really helps reframe, starting out by understanding, well, what is the patient's perspective of this? What do they see as the risk of COVID and of cancer? And then how can we help calm that anxiety and fear around that and reframe it to, we're going to manage you this way to provide the best treatment for you in this situation. And this is really where your risk is. And I just think it's a very helpful graphic to reframe that.
Well, and I think so much of what we do is risk stratification, no matter what that is, that this is just another form of that, but honing in on the tools that we need to be able to provide patients accurate information, because so much of that anxiety or that worry is based off misinformation or lack of information. And so how do we rapidly provide that? How are we sharing that information? And does anyone on the call today, do you have any best practices that you guys have used that have been helpful, or maybe some tools that you've ended up putting together, or ways that you respond to those patient concerns? And I know a lot of you are good educators out there. So if you have any good examples, I know we would love to learn from you.
Honestly, right now, we're not even using any tools. We have a dot phrase on, telling patients to stay home and wash their hands and things like that. But I think a tool like this would be helpful to provide to our team.
Mm-hmm. So we have internal tools, but not necessarily patient-facing tools. Mm-hmm. Yeah. All right. All right. So as we think about the kind of that case question then, and we talked about some of those symptoms, helping patients to differentiate is really important. And I think especially we're in allergy season, all of us are getting kind of sore throats, or we're coughing more because it's seasonal allergy time. How are you guys addressing that to your patients and helping them sort of do it or kind of thinking through family or for our patients? So you guys cannot be quiet on this one, because Dr. Nye and I had this conversation yesterday and today. So you share some of your thoughts on how we.
And I'm going to be quiet for.
So we are living in a world where the world is still happening around COVID. And so I think that's the hard part, is putting that into context. And I think as healthcare professionals, where you're exposed to things more often, that does put us in a hypervigilant situation. But a runny nose, a cough, post-nasal drip from allergies, these are things that are going to happen. And I think the hard part is helping our patients understand that they're also going to be, experiencing some of the real world exposures, even though some of these symptoms overlap with allergies, with treatment side effects, and so forth. So Dr. Sinclair, especially since you are in clinic with a lot of patients who are having unresolved symptoms, how are you addressing that?
I think it's making sure, first of all, that we're still looking for the bread and butter stuff. We're so hyper vigilant around coronavirus right now that it feels like that's what you're looking for. And so, recognizing that it might be sepsis and not coronavirus, which, sepsis in an immunosuppressed cancer patient, very dangerous, and not related to coronavirus at all. But if we're just in coronavirus, we may miss some other signs and symptoms. So I think making sure as clinicians that we're at least keeping to some of the classic issues that we're used to seeing in our cancer patient population, but then adding in the coronavirus concerns as well. And this is where I think a team approach really is important, that you're checking in with your differential diagnosis with other providers to say, am I missing something here? Am I too focused on one thing and not thinking broad enough?
Great. Those are great suggestions. So we're going to transition a little bit and have Dr. Wright kind of join in the conversation, because we know a lot of you have a lot of questions about telehealth, and we want to know a little bit more about how you are addressing that. Dr. Nye brought up that we obviously are using smart phrases and dot phrases, but we also are using a whole lot more telehealth. So in your practice, since the COVID-19 pandemic kind of kicked off, are you using different types of levels of telehealth? And Tracy, I am going to let you fully control the poll. And if we want to put that up. we want you to answer the following. Since the COVID-19 about a month ago kicked off, are you still in the setup phase with equipment, track, kind of putting together your workflows? Is it already now part of a standard workflow? Or are you kind of in that we're not even there yet sort of phase? So go ahead and answer the following question. All right. So it looks like there's a few folks still in the putting it together. There's a lot that it's now part of the standard workflow, which has happened, as we all know, very quickly within a week to 2 weeks. So that's great. And Dr. Wright, we'll let you kind of go into the next question here about telehealth resources.
Right, and I know that we reviewed this a little bit last week, but I just kind of wanted to update everyone that, our telehealth billing policies are changing by the day, sometimes multiple times a day. So, and what we're seeing is that what we're seeing at that federal level, CMS is giving us some guidance, but it may be in contrast with what we're seeing from Medicaid on the state level. And of course, our private payers really aren't publishing a lot of information about telehealth billing. And they're telling us that oftentimes that's because different employer groups kind of set their provider plans, so they don't have universal information that they can give that really is specific to the plan. So it's important to check these websites and check them regularly. We know that with CMS, they're adding codes pretty rapidly. We had about 80 codes added last week. And with that, one of the things that they let us know, and this is for Medicare, not Medicaid here in the state, but they want for those new codes, and maybe across the board, it's kind of hard to decipher what they said, but they want the place of service rather than be O2, which is telehealth and what we've been instructing people. But the CMS guidance said, keep the place of service the same as it would have been in person, but use the telehealth modifier 95. We're not usually using that GT modifier anymore unless you're a critical access hospital. Everyone else should be using 95 to indicate telehealth. So keeping our billers on top of these regular daily changes is important, because Medicaid in the state is still telling us they want us to use place of service as O2, telehealth. So this can get really confusing. It'll all kind of get worked out in the end, but the better job we do of staying on top of some of this guidance is really, really important. And then, of course, we are hearing from clinical staff, whether you're a physician, a nurse, a behavioral health provider, what kind of training can we give our clinical staff? And we're really, referring people back to the national telehealth resource centers, their professional associations and organizations, and then there are centers, like mine, we're doing the best we can to help clinicians and providers get some of those basic telehealth skills to translate the clinical skills they already have. And I did want to mention that on the CMS level, they published a telehealth toolkit last week that can be found online as well. So right now, we just really have to stay up to date because this information, particularly towards billing, is changing really rapidly.
You brought up last week about, and I love the analogy you used, that this is sort of building the tent. This isn't like the permanent structure. And you said they launched something like 80 new codes. Are these, once again, in the tent structure, sort of temporary, or will some of them potentially sustain and last, or is that still to be determined?
That's to be determined. We just don't know. We also don't know how open that door is going to stay to telehealth billing to the client or patient in the home. I mean, right now it's essential. We don't know how much that's going to stick. So these are codes. They're not brand new codes. They're codes that have been billed in person for quite some time. They've opened them up to telehealth. We're going to hope that some of these telehealth changes are going to change, that they're going to stick. But I think they're really going to have to look at the metrics on it and really get a sense for, will they be utilized going forward? Is there an added value to remaining with telehealth? So we're going to have to wait and see.
Sorry about that.
That's fine.
Kind of went crazy. I don't know what's happening here. Sorry. Yeah. So the tent is being built. We don't know if it will stay and become more brick and mortar. And that kind of fills into, okay, best practice. And that's where you put together kind of some quick tips for that best practice. And Vicki has just shared with us that she did her first telehealth visit with the provider joining in via telehealth, but the patient still came into clinic. So what are your tricks for the trade that will be helpful for everyone on the call today?
Right. And you know what? If you look over these really basic steps for setting up a telehealth space, and this is whether it is in clinic or in their home, whether the provider is in clinic or in their home, they really are very similar to your instructions as we started Zoom today, right? What do we need to do to have a good connection? We need to make sure we have some privacy. If we're working with patients that need a caregiver support, we want to make sure that's available. Again, as quiet of a space, as free from distraction is important. When we're doing clinical assessments, we want to make sure we have good lighting on that patient, but we also want to make sure that we have good lighting on the then, of course, a good internet connectivity or Wi-Fi is really important. These are just some of the basic fundamentals. I did some work with some interns last week, and as they came on, we readjusted their space like it was a telehealth space, and it took less than 2 minutes. But
Right.
sometimes just having that training for your patient to really improve the quality of telehealth is really important. And the next time they'll join, they'll have it set and ready to go.
Right. So it's doing a little bit of prep to be ready. And as we can see, lots of people's face here on our screen. We can see Hope is in the great state of Kansas behind her. I do have a distraction of my little cat, but it's better if he sits here than if I try to fight with him because he will not. So we have, we are at home, we are trying our best. And I think that the opportunity to be flexible and help our patients sort of onboard is really important because it's very new for them. And for a lot of our peers, it's new, even though it's not new, because we've done teleconferencing for years, but there's still an element where we're taking it to the next level, and we have lots of distractions around us, and we can't always shut them off. So anyone else have any good tricks for the trade? We see Matt has a very nice professional background. That looks lovely. Any tricks from the ECHO Institute, as you guys are pros at telehealth as well? We would love to hear from you guys.
I can't get the green screen on my Mac, so.
So we need some help with that. Yeah, I can't either. The Mac is a problem with green screen. Yes.
So Matt, I'll let you jump in here. I know that we do this just for our participants as we're training people in the ECHO methodology, which is just running through the anatomy of what an ECHO is. And so maybe there's an easy document that could be created about what is expected of telehealth, what are the expectations of the providers and the patients coming on board, and some of the things that you've listed. One of the things we're seeing with distance and e-learning and this uptick in demand for it is that not everyone has access to internet. And so what is the requirement? We do recommend Zoom, and we provide it at no cost to our partners because it's the best with low bandwidth settings, but maybe it would be helpful to establish that and just have a sheet. You guys are so great about publishing things on your website that can be forward facing for your patients. So I'll let Matt jump in here, but that was just a quick thought I had.
Great, Luca, thanks.
Thank you, Luca, and thanks everyone for the opportunity to speak up. I have I'm learning a lot today, and I have a lot to learn with respect to telemedicine or telehealth beyond the ECHO model. And we're all kind of in a situation now where we need to learn it. And so we're actually working on an initiative right now to build up expertise in telemedicine. And we've partnered with a few leaders in telemedicine, and also just heard back from the American Telemedicine Association today. So we're going to be hosting a nationwide telemedicine ECHO soon. So stay tuned, because we all have a lot to learn about just building up our comfort level and expertise in using telemedicine. I've really had zero experience before now using telehealth beyond the ECHO model. I'm at a place in my own clinics at the University of New Mexico where we're doing phone visits, but those are, the reimbursement for that is nothing at all like a virtual visit. So again, I'm looking forward to learning a lot in our first meeting to kind of kick off this national ECHO in the coming weeks is going to be Monday. So I'll definitely keep you posted on my front, on that front. I mean.
So that leads nicely, Matt, into this, which Dr. Wright can tell us a little about, because they have kicked this off locally. And will you kind of enlighten us and tell us how much interest you had just regionally, which I think is a great resource.
Yes. So Matt, you were invited to our ECHO. Now, the ECHO that the Center for Telemedicine has set up really is a rapid response ECHO. So this is not like the deepest dive into building a sustainable, long-lasting ECHO. This is building your telehealth medical tent. And so our goal here is to be kind of a microburst of information about what are the basics you need to know to set up telehealth and get going as quickly as possible. And when we once this crisis is over and we have this learning collaborative built, then we'll look at doing something to provide education on a more sustainable model. But we're doing this ECHO. It's Thursdays at noon. We had over 300 people register within 48 hours when we got this up and going. We had 188 in attendance for our first ECHO last Thursday. So lots of interest. Our attendees were everyone from administrators, clinicians, providers, and our insurance payers showed up to the ECHO as well. And we had, of course, some from KDHE and KDADS on the line. So it was a broad appeal. We're really hoping to support our partners across the state, knowing what they need to know just to get up and get going, knowing that this may not be sustainable. So these are just some resources we've put together. We're very excited to have this ECHO up and going, and you all are invited to join us tomorrow at noon.
So that's a great resource, and that's also going to be in the toolkit. But Carla brought up on the chat box, they are having challenges with older patients and patients that are hearing impaired. And do we have any good workarounds? Like, how are you addressing that, Dr. Wright, when you guys kind of onboard or help facilitate telehealth visits?
Right, and a lot of my background is treating geriatric patients. Fortunately, my contact with them has been in skilled nursing facilities where there's a lot of support. So we do have great workarounds for the hearing impaired, everything from the headsets that we use or how we place a speaker or a microphone to assist with that. The problem really does become reaching them in their home and using technology that they're familiar with. So, right now we have the Office of Civil Rights saying, as long as you're doing telehealth with good intention, we're not going to go after you if you're not using a HIPAA compliant platform, which is great for Medicare. Our state Medicaid has not said the same thing. They want everything to be HIPAA compliant at this point. But if we have those Medicare patients and they're familiar with how to FaceTime their children, then we need to leverage the technology that they're already using. In terms of the lack of broadband, we really do kind of get in trouble there. I've been asked many times, can we sit in the parking lot at the library and use free Wi-Fi? Well, 9.9 times out of 10, I'm going to tell you that's not the best practice. However, in a time of a crisis, if we inform our clients or patients and their caregivers about what risks are associated with using free Wi-Fi, and we're still getting critical care to individuals that need it while protecting their health, then we just need to explain in our client notes what we're doing differently, that we're doing it in the face of COVID, and we're doing the best we can with what we have. So we do have tools that can help elderly, particularly the hearing impaired. Oftentimes those headsets, earbuds, things that can amplify sound can help. And sometimes it's just about getting a caregiver to sit next to them and walk them through the appointment so that they can assist with communication.
Right. That's a great point. And I hate to say we are at the end. I went over and I've been trying to be so diligent, but I do want to ask you guys this last poll question before we finish out, because this is going to help us with our last in the series next week about what topics you're really interested in. And Tracy, do you want to pop up that last poll so we can make sure that we are answering the community's questions? And we really want to know, either in the chat box, please put in any topics. Do you want to hear more about telehealth? Do you want to hear more about risk stratification? And what our last poll is not coming up. Sorry about that, you guys.
It's not coming up because I did not get it put in. I apologize immensely. So I will take it on myself. If you think of something after the fact, please don't hesitate to email me, tmccarty@kumc.edu, and I'll make sure to share it with the planning committee.
Well, we do not mind, Tracy. I appreciate all that you do as our Oz on our echoes. So anyone have any thoughts that you have, please put it in the chat box. We really do want to make sure we're meeting your needs as our community. We'll dive into self-care. I know we keep saying that, but next session we really will. And now that we have some of our new team members who you met tonight joining us, I think it'll be a great discussion. So just remember, we can offer you your continuing education credit using 3 different ways to access it at 71 WALD. We want to see you next week for our last in the mini series, and then we'll go back to our survivorship series. And all of these resources are available at the Masonic Cancer Alliance.org website. So any last comments from anyone in the group, please feel free to share on the chat box, or we will stay on for a couple minutes to answer any other questions. And we want to thank all of you for being part of the community tonight, and we hope to see you next week.
Thanks. And I did put that link for our registration in the chat. You can also find that at the KUMC Project Echo website. If you'd like to just Google KUMC Project Echo, it'll take you to a site where you can find our telehealth echo.
Thank you all so much, and enjoy the sunlight today if you're still somewhere where it's sunny. As you can see, it's coming through. So, all right. Have a good night. Bye.